in the session of DCR. Bit late, but we shall try to finish on time. Topic for today I say is bumpy roads to DCR made smooth. And these are my speakers. There is some reshuffling. Accordingly, I shall change from this place. My speakers is myself, Ajay Kumar Sinha, Amit Raj, Colonel Rajneesh is unfortunately he is not here, Dr. Gyan Bhaskar and Dr. Sudhir Kumar. And although intranasal endoscopic DCR is gaining clinical acceptance and popularity, and the external DCR is regarded as the gold standard in the terms of surgical success with high patient satisfaction. Let me introduce our speakers. It is myself and RIMS Ranchi alumni, and he is Dr. Amit Raj. He is doing lacrimal drainage system. He is currently working as additional professor and head Department of Ophthalmology, AIIMS Patna. He is ex-faculty member, GMSC Chandigarh. His area of interest is cornea, keratoplasty, pediatric cataract. And he's published more than 50 articles in peer-reviewed national and international journals, and members of editorial board and reviewer of various journals, and recipients of Dr. Dukharam Gold Medal by Bihar Ophthalmical Society in 2008 and Best E-Poster Award in Confluence 2013 Hyderabad. Our next speaker is Dr. Gyan Bhaskar, who is dealing with endoscopic and laser DCR. He is professor and unit head 2 at RIO Patna. And he is secretary of Patna Ophthalmical Society, member scientific committee, Bihar Ophthalmical Society, various publications in PubMed and index journals, and he has won all the 3 awards by BOS, Bihar Ophthalmical Society, whether it is for DCR Gold Medal for free paper, best paper, and best video. And our next speaker is Dr. Sudhir Kumar. He is dealing with a step-by-step external DCR. He is currently professor and head, Betia Medical College. And he is an AIIMS alumni, and he holds the position managing editor, Bihar Journal of Ophthalmology, treasurer, Bihar Ophthalmical Society. He is past secretary of Bihar Ophthalmical Society, works for several projects with Rajendra Institute of Medical Research, ICMR Patna. He receives all the 3 awards from Bihar Ophthalmical Society. And our next speaker is Dr. Ajay Kumar Sinha. He deals with case selection, and he is like me, he is an RMCS Ranchi alumni, currently assistant professor at Patna Medical College. He is ex-treasurer, Patna Bihar Ophthalmical Society, and president-elect BOS. Thank you.
For kind words of introduction. As you described, now my area of interest is cornea, keratoplasty, and pediatric cataract. So now I hardly do DCR. In last 5 years of my tenure in AIIMS Patna, I have only done 2 DCR. That is only of basically faculty relative and faculty close friend. So, but during my PG days and in other institute, I have done so many DCR. But the difference is that at that time, basically, anatomy was not so clear to, and so there was lot of bleeding, lot of complication, lot of failure also. But now it is more control. So, as you all know, sorry, just a moment. So lacrimal drainage system consists of main lacrimal gland, accessory lacrimal gland, upper and lower puncta, paired lacrimal canaliculi, lacrimal sac, and nasolacrimal duct. So coming to the main lacrimal gland, it's located in upper lateral tarsal aspect of globe and secrete tears through a series of duct which opens in superior fornix. And it has 2 parts, larger orbital part and a smaller palpebral part. And it is divided by the levator muscle. Orbital part is almond-shaped tubulo-acinar gland, larger and superior part located in the orbital fossa, and it is related to superiorly with periorbita, inferiorly with LPS, laterally lateral rectus, medially LPS. And anterior border is septum orbital, and posterior border is continuous with the palpebral part of the gland. Coming to the palpebral part, it is flattened horizontally. A smaller and inferior part lies over the levator and superior fornix, visual transconjunctival. So, ducts of lacrimal gland pass through the palpebral gland. It is 10 to 12 in number. So, why it is important? If palpebral part is damaged, so lacrimal secretion is basically it becomes low or it may be absent. Coming to the accessory lacrimal gland, it is mainly two accessory lacrimal gland, gland of Creutzfeldt. It is microscopic gland located in the subconjunctival tissue of fornices. It is around 40 to 42 in upper part and 6 to 8 in lower fornix. Gland of Wolfring, it is again microscopic gland. It is 2 to 5 in upper border of superior tarsus and 2 to 3 in lower border of inferior tarsus. It is and other rudimentary glands that can also secrete some aqueous part in caruncle, in plica, and infraorbital region. So basal secretion of tear is secreted by accessory gland, and reflex part is secreted by the main lacrimal gland. Coming to the puncta basically opening of 0.3 millimeter in diameter located in the medial aspect of upper and lower eyelid margin, and each punctum sits on top of the elevated mound known as papilla lacrimalis. Inferior punctum is slightly more temporal compared to superior puncta. The puncta are relatively avascular structure in comparison with the surrounding tissue, giving them a pale appearance which is accentuated with lateral traction of the eyelid. This pallor can be helpful in localizing the stenoid punctum. Coming to the canaliculi, canaliculi have an initial vertical orientation followed by horizontal and approx 90-degree angle. Canaliculi should be dilated at the junction to form the ampulla. Canaliculi pierce the lacrimal fossa before entering the lacrimal sac. That is why basically orbicularis muscle controls the drainage of the tear. In most individual, horizontal portion of canaliculi converge to form the common canaliculi. In others, it opens. Only around 10% it may open separately. So, common canaliculus may dilate slightly, forming a sinus of Mayer at the junction of the sac. So, while probing or syringing, first orientation should be vertical, and then there should be lateral traction. Then one should go for syringing. Otherwise, there is chances of false passage formation. Similarly, again, while probing, especially one should go from the upper canaliculi. So, oblique entrance of the common canaliculus into the lacrimal sacs forms the valve of Rosen-Muller, which prevents retrograde reflux of fluid from the sac into the canaliculi. An incomplete valve of Rosen-Muller is observed clinically as air escaping from the lacrimal puncta when individual blows her nose. So, coming to the lacrimal sac sits in the lacrimal fossa, and it is bounded entirely by the frontal process of maxilla bone, and that is called anterior lacrimal crest, and posteriorly by the thin lacrimal bone known as posterior lacrimal crest. Differing proportion of lacrimal bone and maxillary bone make the lacrimal fossa, and its dimension is approximately 16 millimeter high, 4 to 9 millimeter wide, and 2 millimeter deep. For endoscopic DCR, one should able to localize the lacrimal bone. So, intranasally, its position is anterior to the uncinate process of the ethmoid bone. So, first surgical tip is avoid injuring to the angular vein during a skin incision. Safest skin incision is over anterior lacrimal crest. How it will be basically localized? One should feel the inferior orbital margin, and then by going up, one can feel the anterior lacrimal crest. So, third surgical tip, one should restrict the bony window area between the anterior and posterior lacrimal crest. That is called lacrimal fossa. As going beyond it, especially downward, can open into the paranasal sinuses. So, what are the relations of lacrimal sac? Medially, there is periorbita and bone, arc of ethmoid sinuses, lateral skin orbital orbicularis oculi and lacrimal fossa anterior, medial palpebral ligament and angular vein, posterior lacrimal fossa and muscle. So what are the parts of lacrimal sac? It is divided into
Dr. Amit, we are running short of time.
yes,
That's why.
it is divided into fundus and body. Fundus is 3.5 millimeter above the superior portion of medial canthal tendon, and body is 10 millimeter below the fundus. So these are the relation. So why it is important to know the superficial head and deep head of the orbicularis oculi? It encompasses the medial canthal tendon. So basically, when you are cutting the orbicularis muscle, you will cut the tendon. So there should be blunt separation. So surgical tip number 4 is separate the orbicularis muscle using blunt dissector or bait gauge piece, and never cut them to avoid bleeding and loss of lacrimal function. Last one is the nasolacrimal duct. It is again divided into two parts: intraosseous part and a membranous part. Intraosseous part is longer compared to the membranous part. There are many valves, but main important valve is Rosenmuller valve, that is between canaliculi and sac, and the Hasner valve between the inferior meatus and the lower part of the nasolacrimal duct. The valve of Hasner is important as it opens opening in the nasolacrimal duct, and it is imperforate in around 70% of newborn, but there is a spontaneous opening in 6 to 12 months. So it is not that before 6 months one should go for syringing probing. First one should wait, or one should go for Kriegler massage. Conservative management should be done. So vascular supply, it is by lacrimal artery, sensory supply by lacrimal nerve, and so my take-home message is with proper understanding of anatomy of lacrimal drainage system and the anatomical landmark, success rate of lacrimal surgery can be maximized. For a skin incision, trace anterior lacrimal crest by palpating upward from the inferior orbital margin. Injury to angular vein can be avoided by making a skin incision on anterior lacrimal crest. Orbicularis oculi is essential for lacrimal pump function. Therefore, the fiber must be separated by blunt dissection, never cut. In infants, with watering imperforate valve of Hasner may be the cause. Chances of a spontaneous recanalization after conservative management is high. Thank you very much for present here.
Thank you, Amit, Dr. Amit. We shall take question hour session at the end, because we get dash 15 minutes later. So our next speaker is Dr. Ajay Kumar Sinha. He will dealing with a case. He is dealing with a case selection in DCR.
Good afternoon, dear delegates. Firstly, I would like to thank our chairman, Dr. Ravi Ranjan, for believing in me and giving me this opportunity. And secondly, I have no financial interest in this presentation. Dear friends, all of us doing DCR surgery must have experienced that the road to a successful DCR is not as smooth as we would have liked. It's really a bumpy one. And that's why today we are here to make this road as smooth as possible. To minimize the failures and make the road a bit smoother, case selection is very important. Now let us remember some guidelines for a successful DCR surgery. Number one, I would like to say that the best sac for doing DCR surgery is the one with a mucoceal. Why? Because the sac is bigger and it will be easier to make the flaps. And number two, the best patient, ठीक है अभी इसी पर है. The best patient for doing DCR is a thin, frail, elderly patient with roomy nostrils. Now, how can we make the road to the DCR smoother? Number one, first and foremost, we will have to differentiate whether this is a case of epiphora or a case of hyperlacrimation. Number two, after we have confirmed that it's a case of epiphora, we will have to evaluate the lacrimal drainage system and establish that the blockage lies somewhere distal to the sac or in the NLD. The sac ka status we'll have to see. Whether the sac is having some functional loss. Nasal pathology, we should exclude nasal pathology, because if this epiphora is because of nasal pathology, then doing DCR will not cure it. So we'll have to treat the nasal part, and then this epiphora will get cured. Let's start from the symptoms, right? Even a simple question कि पानी कहाँ पे, पानी गाल पे चूता है कि नहीं चूता है, this will indicate tears overflowing onto the cheek is likely to indicate drainage failure rather than hypersecretion. The other thing is location of the epiphora. Tears medially or centrally, they indicate epiphora related to nasolacrimal duct obstruction. Apart from this, mucopurulent discharge, matting of the ilices, these all symptoms will be present. Let's move on. Again, laterality and duration. This is important. Let's start our examination. In external examination, let's concentrate first on the punctum. Punctal abnormality is the most common cause of lacrimal drainage failure. But in our case, if this is the cause, DCR is of no use. So we have to choose the patient which is fit for DCR. So we'll have to rule out punctal stenosis, ectropion, any lid pathology, ectropion. This might be causing epiphora. But then DCR won't help. Next. Regurgitation test. This is an important test which we do. And regurgitation test of mucopurulent material on compression is indicative of a mucocele with a patent canalicular system, but with an obstruction either at or distal to the lower end. Because if punctal reflex is taking place, this means that the anterior lacrimal drainage system is patent. Again, fluorescein disappearance test. This test, what do we do in this? The fluorescein disappearance test is performed by instilling fluorescein 1 or 2% into the conjunctival fornices. Normally, little or no dye remains after 5 to 10 minutes. But if the dye is still present, that means prolonged retention is indicative of inadequate drainage system. The drainage system is not adequate. So now we have to find out where is the cause. We'll do lacrimal irrigation and probing. We can do with this. Look, last point. If saline passes into the nose and throat, tested by the patient, a patent lacrimal system is present. So the system is patent. Then again, no DCR needed. Probing. While probing, we may get a hard stop or a soft stop. Now, hard stop indicates that the cannula has entered into the sac. This means the anterior lacrimal drainage system is patent. Soft stop. What does this mean? You could not enter the sac, either canaliculi or common canaliculi, somewhere that might be causing the obstruction. Soft stop.
Next slide, sir.
Then another Jones dye testing. Now, dye testing is indicated only in patients with suspected partial obstruction. Epiphora is present, but there is no punctal abnormality, and the patient tastes saline in his or her throat on irrigation. Now, the primary test. The primary test differentiates between partial obstruction of the lacrimal passages and lacrimal pump failure from primary hypersecretion of tears. What do we do in this? A drop of 2% fluorescein is instilled into the conjunctival sac of one eye only. After about 5 minutes, a cotton tipped bud moistened in local anesthetic is inserted under the inferior turbinate. And what are the results? Positive. When do we say it's positive? Fluorescein recovered from the nose indicates patency of the drainage system. Watering is due to, now, if fluorescein is recovered, this means watering is due to hypersecretion because the system is patent. So no further tests are necessary. But if Jones dye test is negative, then what do we do? No dye was recovered from the nose. So this will indicate either it's a partial obstruction or lacrimal pump failure. In this situation, secondary dye test is performed immediately. What is this secondary irrigation test? Topical anesthetic is instilled and any residual fluorescein washed out from the conjunctival fornix. Now the drainage system is now irrigated with a cotton bud under the inferior turbinate. Let us see what the results are. Positive. When do we call it positive? If fluorescent stained saline is recovered. So previously this was not there, but after draining the system, we got some fluorescent stained material. So this says that partial obstruction of the nasolacrimal duct is there.
Pointer.
So negative. Now what do we understand by the negative test? Unstained saline recovered from the nose indicates that fluorescent did not enter the sac. So this implies the upper lacrimal dysfunction, which may be due to partial physical occlusion and pump failure. So thank you. We have selected the case, and now over to the surgeon.
Thank you, Ajay sir. Our next speaker is Dr. Gyan Bhaskar. He is dealing endoscopic and laser DCR. Dr. Gyan, be fast because we are running short of time.
Thank you so much, sir. First of all, I'd like to thank you, sir, for giving me the opportunity, and thanks to AIOC. I'm going to discuss about the endoscopic and laser DCR. After the proper knowing the anatomy and case selection, and the step-by-step DCR will be discussed by the Sudhir sir. As we know, so basically DCR creates a surgical opening between the lacrimal sac and the nasal mucosa just posterior to the anterior lacrimal crest. But why there's a need of so many techniques? even though there is the external DCR is proven and success rate is high. Why there is a need of endoscopic and laser DCR? Because some patient, different patients are presented with a different clinical scenario, with a different problem. Just to see here the patient with a young lady presented with the watering and mucoid discharge, and she wants cosmetic as well as resolve the problem without any further complication. Another young girl presented with the mucosis, insisted mucosis, and she also want good result without any cosmetic disfiguration or a scar on face. And another old female presented to us with the nasal obstruction with systemic comorbidity. And other young child presented bilateral insisted mucocele, and another patient is presented with the acute dacryocystorhinostomy periseptal cellulitis. So different cases have different problem, and we have to think according to the problems. So that's why there is a need of multiple or different approach for the management. As initially just we transnasal DCR was first described by Cadwell in 1893, but it was not gained popularity due to the poor illumination of the nasal cavity and intraoperative bleeding. But nowadays, advancement of the newer techniques and technology, these techniques are gaining widely accepted and doing most of the people are doing. And laser DCR was first described in 1990s by Masaru et al. And there were so many papers published with the different results. So here I am going to discuss about the lasers used in the endonasal DCR. There are so many lasers, that is the potassium titanate phosphate, aluminum YAG laser, diode laser, argon laser, convex laser, but the most commonly used laser was the KFT and diode laser. So diode laser property of diode laser is work as a contact mode and create and evaporate and coagulate at the site of the contact only. And it has the different fiber optics, 200, 400, 600 microns, and because the smaller the size of the diameter of the diode laser has the more energy power of the tips. So commonly 400 microns diameter diode, optic fiber were used, and it needed a metal guided wire, because if we deliver the energy, it causes the burn of the punctum and lead and canaliculi. That's why metal guide wire were used to prevent the iatrogenic complications. So power was used was 8 to 10 watts. It acts fast and deep incision, and pulse was 50 millisecond. It would be the gentle, and it's help in gentle and precise incision. Above that power, it lead to the iatrogenic burn to the canaliculi and the mucosa. And proper case selection is very important while doing endoscopic or any DCR. Generally, we avoid DNS. Medial terminate hypertrophy, canacular blockage, or acute dacryocystorhinostomy should be avoided in cases of endoscopic or laser DCR. Preoperative preparation and techniques are the before going to the any surgery. Local anesthesia should be proper, so that surgeon and patient should feel comfortable. And patient place supine position at 50 degree, and appropriate laser safety should be used. Just to see the proper anesthesia, we should block the at least 4 block nerve, infraorbital nerve, anterior spinal nerve, intertrochlear nerve, and dorsal nerve should be blocked. And then after proper dilatation of the punctum, we should also use upper punctum, because if any, we should not disturb the lower punctum for the DCR, any kind of DCR probing or dilatation. So after the dilatation of the upper punctum, a probe is or optic fiber is introduced through the canaliculi and reach up to the bone, and once you feel the hardness, then you start the laser to create opening and make the ostium at the bone and create the opening in the mucosa. Just you see here, and it also should be visualized endoscopically so that you should be ensured that the opening should be in front of the common canaliculi and it should not and in front of the medial concha. That's why and if you pierce the mucosa, then laser probes should not touch the septum. So otherwise, it lead to the burn and later on the fibrosis. After the osteostomy, silicone tube was implanted by cannular silicone tube was implanted and it was secured. And MMC, mitomycin C, applied for further any fibrosis. And should be keep in mind the tube should be removed after the 4 weeks. Don't lift the tube more than that. Otherwise, it lead to the sometimes canalicular injury, punctal injury. So the advantage of and every surgery has the advantage and disadvantage. Advantage should be it performed on the local anesthesia, can be performed in the patient is on anticoagulant and shorter operative time, more effective hemostasis and low hemorrhage rate can be occur, and it should be done in case of failed cases. And complication and disadvantage it sometimes the low success rate, high cost, and laser precaution is required. So indication of the endoscopic and laser DCR is if there is a nasolacrimal duct obstruction. In cases of failed DCR, patient is unfit for general anesthesia, then we can go for, and the patient is on anticoagulant therapy. So complication is either if there contraindication if patient is on if suspected tumor, AIOC2023, if there is a thick or post traumatic cases, or then is there lacrimal passage pathology, it should not be done. So post-op care should be taken oral antibiotic, anti-inflammatory, nasal decongestant, topical antibiotic, anti-steroid eye drops should be given, wash of the nasal cavity with saline should be done, repeated syringing sometimes may required. Complication and failure, every surgery have its own complication and failure rate. So in laser surgery it causes stenosis, granuloma formation, there is a synechia with the nasal mucosa, sometimes stent migration, and if there is the opening is not on the proper way, then some syndrome can occur, and sometimes cutaneous fistula can occur, and a small failure is due to the small ostium and inappropriate site of osteotomy or canalicular occlusion may lead to the cause of failure. So conclude that endoscopic or laser DCR should be preferred in young female patient. They are really whether for the cosmesis. It should be performed under the if there is a failed cases, and of course it's patient on anticoagulant medication should be done. Thank you so much, sir, for
Thank you, Dr. Gyan, for that didactic lecture. Our next speaker is Dr. Sudhir Kumar. He is talking on a step-by-step external DCR. Sir.
And good afternoon, everybody, and thank you, AIOS, and thank you, Ravi Ranjan.
Yeah.
As we have discussed about the nasolacrimal duct block, and the treatment is still DCR, either external or internal, and there are many variations in the external DCR. But before that, we must see that the basic surgery, which is much needed, and we must do several external DCR with conventional methods, so that you can always improvise upon that. So the functional goal is, as usual, relieving the symptoms of epiphora, discharge, and recurrent inflammation, and this is achieved by achieving anatomical goal, which is nothing but creating a bypass of blocked NLD by making a fistula between lacrimal sac and nasal cavity. And this is achieved by making a large bony ostium. This is one of the most important thing. And having a mucocele lined anastomosis, then it becomes fistula. So as we have discussed, indications are primary and secondary nasolacrimal duct obstruction, and congenital nasolacrimal duct obstruction not responding to probing, or when it is associated with mucocele. So before we go into the DCR, DCR is notorious for hemorrhage. So, and before we do, there are many chances that we may misdiagnose the case of epiphora as NLD blocked. So first confirm the diagnosis of nasolacrimal duct, and the simplest method is positive Rhoplast. This just you press over the medial canthus, there will be regurgitation, and you can confirm it through nasolacrimal duct syringing, or if you find something abnormal or you find some mass there, you can always go for DCG, and DCG means Dacryocystorhinostomy, and it's a very simple X-ray method, and this can also be done in repeat surgeries. And apart from that, since it is just notorious for hemorrhage, so hemoglobin and blood grouping should be done, BTCT, and control of hypertension and diabetes as in any other surgery, and any other GA requirements if it is to be done under GA. So most of the time it is done under LA, especially in adults. But some cases are contraindicated for DCR, because if you suspect malignancy, it's absolute contraindication, malignancy of the sac, nasal cavity, etc. In atrophic rhinitis, there is atrophy of the mucous membrane, nasal mucosa, and so the patients might present with foul smelling, but he will be having anosmia. At the same time, dry eye, if you do DCR, then you are making the patient at some disadvantage, because he needs more tear. So, and in any bleeding disorders, tuberculosis, rhinosporidiosis, and even in old age, you can go for simply DC. You can go for Dacryocystorhinostomy rather than DCR. So the patient is prepared. Control of blood pressure. Stop any blood thinners if he is taking. Nasal packing. Do the nasal packing soaked in xylomethazolone or xylocaine and epinephrine. And before we go into the details, as we have discussed here, the anatomy, this is this lacrimal fossa, and this is anterior lacrimal crest, and this is posterior lacrimal crest. In between this, the sac lies. Under the skin, there is orbicularis muscle, which makes medial palpebral ligament or canthal ligament, and the medial canthal ligament has two crusts which wraps around anteriorly and posteriorly over the sac. And as far as we should not try to disturb this structure during the surgery, and if it is cut during the surgery, for better exposure to the sac, it should be repositioned as where it is. So this is nothing but DCR is nothing but making a fistula between the sac and the nasal cavity in the medial antrum. And without going into the details of the various names of the nerves, you have to block inferior to the sac. This will block the inferior orbital nerve, and you inject sufficient bupivacaine and xylocaine mix here, and similarly superior orbital nerve can be blocked through this here and this place, and that is in between the near the anterior medial 1/3, at the junction of medial 1/3 and lateral 2/3, and another block should be injection should be given anterior to the sac, and then it is inserted. The needle is inserted deeper so that it can block further deep inside and same can be repeated from the posterior side of the, or rather lateral side of the sac itself. So this should be done around 10 minutes before you have planned for surgery. That will give sufficient anesthesia and hemostasis, because most of the time we use xylocaine with adrenaline. So these are the positions we have discussed. So incision making is very simple. There is two school of thought, but most of the time 3 to 4 millimeter incision can be made 3 to 4 millimeter medial from the medial canthus, and because the angular vein lies around 7 to 8 millimeter medial to the medial canthus. So this is the most popular incision, where you trace the anterior lacrimal crest, and this goes above till the medial canthal ligament. And then blunt dissection is carried out to reach the periosteum, and periosteum elevator is used to separate the periosteum from bone and reflect it laterally. And after retracting this, the lacrimal fossa is exposed, and then lacrimal bone is thinner bone which is punctured, and then it is extended anteriorly, superiorly up to the ligament, and then inferiorly to the nasolacrimal duct junction. That is most important. Otherwise, this may fail. And around it comes around 1 finger can be put into the hole, and then both the sac is nasal sac, mucosal sac, and lacrimal sac is exposed here, and you can easily identify these structures and cut the lacrimal sac in this fashion, and you can give you can augment this in anesthesia with further giving an injection, and then this can be cut, and excess part can be removed, and then sutured tightly and anchored to the structure. There are intraoperative complications.
Sir, complication will be dealt separately.
It has been okay, and with this I say thank you.
Okay, thank you, sir. Next is me. My topic is DCR made simple and complications. Now we come to simplify this procedure, DCR. Although intranasal endoscopy DCR is getting clinical acceptance and popularity, the external DCR is regarded as the gold standard in terms of surgical success with high patient satisfaction. And personal communication with many ophthalmologists reveal that the failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery. That is why we change the surgery to make this less time consuming, easy to perform, result at par, and short learning curve. And changes we made is medial part of the lacrimal sac was removed, saving 2 mm to 3 mm of sac around common canaliculi. Aruga's bone refined is used here to make ostium, and mitomycin C is used on 5th day of syringing in the newly formed passage. And after the initial success, we planned a study, and currently from March 2010 to March 2020, total number of patients we have taken 3768. Methylene blue is used to irrigate lacrimal sac to delineate it during dissection, and curvilinear skin incision was made 1 to 5 mm to 2.5 mm away from medial canthi, like this. Medial 2 to 2 mm to 3 mm of the sac around common canaliculi is shaved so that the lateral part of the sac remains as a disc with punctum in its middle, similar to a funnel. And here A is showing remaining sac after the small flap and tip of the Bowman's capsule coming out of the common canaliculi opening. 10 mm Aruga's bone refined was used to make ostium in lacrimal bone and passage in nasal mucosa. And this one is Aruga's bone refined 10 mm. I used 10 mm Anterior part of the lacrimal sac. Remaining sac was sutured with the subcutaneous tissue of the medial side, adjacent to newly formed ostium by non-observable 6O silk thread. Medial palpebral ligament and rest of the incision were sutured. On 5th post-operative day, sac syringing with 1 ml of 0.4 milligram per ml mitomycin C was done, and all the cases were followed up for 1 year. No unexpected complication was found during surgery now. And the patient were followed up for 1 year, and functional success was defined as absence of tearing, assessing the Monk score, and epiphora of grade 0 to 1 was considered as a success, and anatomical success was defined as a patient with no significant reflux on a syringing test. And ostium size was measured using nasal endoscope, and in one case this is nasal endoscopy after 1 year, and this is internal nasal opening here. And the endoscopic view after 5 days, and these are the endoscopic view after 15 days, after 1 month, after 3 months, after 6 months, and this one is after 1 year. And the ostium size shrinkage was one, actually it is not related to this study, and the result were analyzed after end of a study, and 3715, that is 98.66% patients were successful at the end of mean follow-up period, and 21% complained of epiphora of grade 2 or more, and sticky eye despite successful syringing and patent newly formed nasal ostium, and 27 patients failed in syringing during the follow-up periods due to closure at osteotomy site. And thus in our study, anatomical success is 3736, that is 99.15%, and functional success is 98.66%. And speaking some point, in our studies, frequent cause of DCR failure was closure at rhinostomy site and inappropriate size and location of the bony ostium. And we use here 0.4 milligram 5 ml because it was found safest and most effective. And why on 5th post-operative? Because in the present study, syringing of 0.4 milligram per ml mitomycin in the newly formed lacrimal passage on 5th post-operative day, because it decreased the incidence of post-operative adhesions more significantly, because it is not diluted by bleeding from nasal mucosa, and better coincides to early preoperative phase of healing, which starts from 3rd to 5th day of tissue injury. And we conclude and recommend this method because this method is easy to perform with reliable and comparative result, as you have all seen. Needs no costly instruments, can be used for mass surgery in camps, can be used for repeat and very large dacryocystorhinostomy. And complication, I have to take it. And as usual, hemorrhage, primary or secondary hemorrhage. The most important complication in DCR surgery is SUMP syndrome. May occur if the rhinostomy is rhinostomy size is small and high up in the lacrimal sac, and this causes tear and mucus to accumulate in the sac and discharge into the eyes. That should be taken care of. Late complication may be rhinostomy, fibrosis, weft facial scar, medial canthal distortion, epiphora, and failed DCR. Thus, we can conclude the most frequent and important complication of DCR was failure and recurrence of epiphora or pleural discharge, and the less frequent complication included a scar formation, wound infection, and granuloma formation. And there was no complication during operation here. And we have had this type of cases by these methods. Thank you. And thanks for patience hearing. Any question? Thank you, Gagan sir, for